Hi, my name is Gustavo Odrich. I'm professor of surgery at the Division of Vascular and Endovascular Surgery at the Mayo Clinic. I would like to thank Dr. Mangialardi and colleagues in Rome for the kind invitation to participate at the meeting today. I'm sorry I was not able to come, but hopefully there will be future opportunities for us to collaborate. I'm presenting to you about endovascular repair of post-dissection thoracoabdominal aortic aneurysms. These are my disclosures. To illustrate, I'll present one of my patients that has been recently treated. This is a 74-year-old male with an enlarging 6.6 centimeter extent to thoracoabdominal aortic aneurysm after a DeBakey 3B or Stanford B aortic dissection in 2010. In 2015, he obtained a CT angiography of chest, abdomen, and pelvis, which showed fairly extensive dissection starting in the proximal third of the thoracic aorta. This dissection extended throughout the celiac axis, the SMA, and both renal arteries. Note that the celiac, SMA, and the left renal artery originate from the true lumen, but the right renal artery originated from an isolated false lumen. The patient was followed and treated with a thoracic endovascular aortic repair in 2015. He then had progressive enlargement of the distal thoracoabdominal portion of the aneurysm. His cardiovascular risk factors included cigarette smoking, ischemic cardiomyopathy, multiple myocardial infarctions and coronary stents, stage 3 chronic kidney disease, hypertension, hyperlipidemia, morbid obesity, and moderate COPD. On physical exam, he had normal vital signs. His heart and pulmonary exam was unremarkable, and he has normal peripheral pulses. His diagnostic evaluation included a serum creatinine of 2.1, normal ECG, unremarkable chest X-ray, and a dobutamine stress test echocardiogram which showed regional wall motion abnormalities consistent with his previous myocardial infarctions. He also had a repeat CTA of chest, abdomen, and pelvis. This CTA was done after the previous thoracic endovascular repair of 2015, demonstrated that the proximal thoracic aorta had occlusion of the false lumen all the way to the distal edge of the thoracic stent. On the axial views, you'll see that there is full expansion of the true lumen in the proximal thoracic aorta. There is predominant flow via the true lumen in the chest, although there is refilling of the false lumen in the distal chest. Again, the celiac axis, SMA, left renal artery originate from the true lumen, and the right renal artery, as depicted here, originates from an isolated false lumen. This slide is a summary of the diameters of the aorta, including a diameter of 5 cm in the treated segment in the chest, 6.5 cm in the infrarenal aorta, and 5.5 cm at the level of the SMA. Also noting here that the SMA originates from the true lumen, as does the celiac axis and the left renal artery, and the right renal artery originates from a fairly isolated false lumen. It is a little subtle to see, but there is a small reentrance site at the level of the superior mesenteric artery. We planned a definitive distal thoracoabdominal repair using a 4-vessel, patient-specific branched endograft. What's new about this device is that it's low profile and it has a specific delivery system which includes preloaded guide wires into each one of these branches. These preload guide wires come inside a nose cone of a 7-French sheath, which is designed to exit via the brachial approach, hosing these 4 wires. Once the sheath is withdrawn through the brachial approach, the 4 wires are revealed and labeled to each specific vessel. That allows sequential catheterization of the renal and mesenteric arteries. It's very important on this case our spinal cord injury prevention protocol. We use a staged aortic coverage as depicted here with previous TVAR followed by the completion thoracoabdominal repair, permissive hypertension, routine CSF drainage for 48 to 72 hours, neuromonitoring, and early limb reperfusion. This is how we use the information of the neuromonitoring during the case. If the patient has no changes in neuromonitoring, we complete the procedure in the standard fashion. However, if we experience a decline in motor evoked potentials, that triggers specific maneuvers including higher CSF drainage and increase in the mean arterial pressure. If these maneuvers reverse the changes, we then complete the repair. However, if there is no reversal, we then restore flow to the lower extremities, and we expect within a few minutes there will be a complete reversal of the motor evoked potential changes. If there is reversal, we then complete the repair. However, if there is no reversal, we leave the repair incomplete by not placing either the celiac stent or the contralateral gate of the bifurcated device. This is a video of the actual case. The procedure was done in our GE Discovery IGS 740. We use onlay fusion, which was prepared just immediately prior to the procedure as depicted here. This was done with bilateral percutaneous transfemoral approach using per-close ProGlide technique. We also use exposure of the left upper brachial artery. Axis is now established in the left brachial artery, and the descending thoracic aorta is selectively catheterized. Using an Amplatz wire, a 12-French sheath is advanced at once with a single pass to the descending thoracic aorta. We then snare the brachial wire to establish brachial femoral axis. My preference is to use the metal wire for that. We tend to match the fusion with angiography. On this case, the catheter immediately went to the celiac axis. So we did the celiac angiography, but usually this is done with the renal artery. The device is now oriented extracorporally. It's important to pay the extra time on adequate orientation of the device. Now the device is introduced first with the 7-French nose cone via the transfemoral approach, noting that the device is now passing via the renal mesenteric arteries. The tip of the device then exits via the brachial approach. The sheath is then removed, revealing the 4 wires in the brachial approach. These wires are already labeled for the celiac, SMA, and renal arteries. Now we do sequential deployment of the device. First, the device is released up to the level of the celiac branch. The sheath is then advanced to the celiac branch, and a buddy catheter is used to selectively catheterize the celiac axis marked here with the green ring. Once the celiac is catheterized, a 0.018 wire is left in the celiac axis, and the same process is repeated now for the SMA. Next, we directed our attention to the right renal artery. We tried first to selectively catheterize the reentrance site. However, this was not successful when we used an outback catheter. You can see here with the illustration the needle of the outback catheter perforating the septum and the small wire now going into the false lumen. One of the first steps then was to document that the catheter was indeed in the false lumen, and once that was done, a fenestration was enlarged with balloon dilatation of a 3 mm and a 10 mm angioplasty balloon. We then confirmed with angiography that indeed we were in the true lumen, and the right renal artery was selectively catheterized, and a rosin wire was placed in the right renal artery. Finally, the distal part of the device was then unsheathed, and now we selectively catheterized the left renal artery, remembering that on this case the patient had a smaller distal branch and a larger upper lobe branch. We then selectively catheterized both branches, first the distal one, and now with a buddy catheter the upper branch. Because we were not able to land the target stent within the main trunk of the renal artery, we actually embolized a smaller branch to avoid a type 2 endoleak. At this point, the delivery system was then removed, and the attachment sites were dilated with coda balloon. And now we have the options of either completing the repair and restoring flow to the legs or directing our attention to the side branches. This is the time we judge our neuromonitoring. On this case, there were no changes in motor evoked potential, so we elected to continue with the target vessel stenting. First, a VBX stent was advanced on the left side, balloon inflated, and the proximal part was flared with a 7 mm balloon, followed by selective angiography. The same process was now repeated with the right renal artery, again using the VBX balloon expandable stent graft, flaring, and final angiography of the right renal artery. We then exchanged the .018 wire in the SMA for a .035 and Platzer wire, and exchanged the sheath to an 8 French Raby sheath for advancement of an 8 mm balloon expandable VBX stent graft. The stent graft was then completely deployed, flared, and a final SMA angiography demonstrated that the vessel was patent with no dissection, embolization, or endoleak. At this point, we then directed our attention to the celiac axis. The .018 wire was again exchanged to an M-Platz wire, an 8 French sheath was advanced to the celiac axis, and then the VBX stent graft was placed in position, inflated, and a selective angiography demonstrates here widely patent celiac axis. Finally, the procedure is completed with placement of a bifurcated universal device, which was now introduced via the left side, and extension to the left common iliac artery. We attempted to catheterize the gate via the femoral approach without success, and therefore the wire was routed via the brachial approach through the contralateral gate and out via an 8 French sheath in the right femoral axis. Once the new brachial femoral axis was established, we then extended the repair to the right common iliac artery. We finally finished the procedure with balloon dilatation of the attachment sites and landing zones and a completion angiography using standard technique, and also a cone beam CT with and without contrast using high resolution imaging as depicted here, with demonstration of the coronal view and also the sagittal view, revealing no evidence of technical defects, compressions, or endoleaks within the stent. This patient progressed well without complications and was dismissed on 5 days. This case also illustrates the extensive repair of a thoracoabdominal aneurysm in multiple stages, first with thoracic endovascular repair, and then with a completion branch endograft to connect to the distal landing zones. I would like to thank the program committee for the opportunity of presenting this to you today, and now I'll make myself available to answer any questions.